Thank you for joining our webinar today to discuss revolutionizing healthcare with AI, unveiling Cedars-Sinai Medical Center's insights and impact on Pulmonary Embolism Response Team, or PERT, with Aidoc. My name is Deepak Shrikant, and I'm the Director of Cardiovascular Product Marketing here at Aidoc. And before we get started today, I'd like to mention a few housekeeping items. This session is being recorded, and that recording will be sent to all registrants after the session is over. Should you need to drop off early, or if you'd like to share this recording with a colleague, be on the lookout for an email with the link to the recording in the next few days or week. Also, if you have any questions during the presentation today, feel free to share them in the Q&A box as the presentation is happening, and we'll address as many of them as we can at the end of today's presentation. So if you're tuning in today, you probably know that pulmonary embolism, or PE, poses a significant clinical challenge with up to 100,000 deaths annually in the United States alone. It's ranked as the third leading cause of cardiovascular death. And historically, there has been variability in treatment across institutions and physicians. And this has underscored the need for standardized strategies, particularly for submassive or massive PE cases. In response, physicians have embraced multidisciplinary models similar to tumor boards or rapid response teams, and that's culminated in the creation of Pulmonary Embolism Response Teams, or PERTs, a little bit more than 10 years ago. PERTs have revolutionized PE care by bringing together diverse specialists to formulate tailored treatment plans. Initially, care coordination was done by pager, phone, email, and video calls. Fast forward to today, and more than 100 healthcare institutions in the US have established PERT programs, but much of the technology has remained the same. Today, we're going to explore the integration of artificial intelligence into a PERT workflow. Artificial intelligence can help facilitate more efficient and effective management of pulmonary embolism cases. Our esteemed panelists, Dr. Jonathan Steinberger and Dr. Maida Yacoub, will share insights and experiences from the Cedars-Sinai AI journey, which, by the way, was the very first US hospital to work with Aidoc back in 2018. I'm very excited to introduce our two guest speakers. Dr. Maida Yacoub is currently an assistant professor of medicine in the Department of Pulmonary and Critical Care at Cedars-Sinai Medical Center. She completed her medical school training at Buckeye Medical University and residency at Sheikh Khalifa Medical City in Abu Dhabi before joining St. Elizabeth's Medical Center, Tufts School of Medicine in Boston, where she was the chief resident. Dr. Yacoub completed a fellowship in pulmonary critical care at the University of Illinois Hospital in Chicago before joining Cedars-Sinai. Last but certainly not least, Dr. Yacoub is the co-director of the Pulmonary Embolism Response Team. In addition, we have Dr. Jonathan Steinberger, who is currently a vascular interventional radiologist at Cedars-Sinai Medical Center's imaging group. He completed his medical school training at the Icahn School of Medicine at Mount Sinai and his residency at Mount Sinai Medical Center, both in New York City. He's a graduate of the Stanford Biodesign Innovation Fellowship Program, which he completed before joining UCLA Health for an interventional radiology fellowship. Dr. Steinberger has held the role of assistant professor of vascular and interventional radiology at the Daughter Interventional Institute of Oregon Health and Science University before joining Cedars-Sinai Medical Center in 2017. As you can see, we have two very experienced clinicians as part of a multidisciplinary PERT team who have truly turned their talents into understanding how to successfully bring artificial intelligence technology into the PERT workflow. So Dr. Steinberger and Dr. Yacoub, I turn the podium over to you. I'll stop sharing here so that you can share your screen. And you just have to.
Good morning, everybody. So we're just working out one last minute technical glitch here, but hopefully this is going to work. What do you have here?
That's good. It's sharing.
It's sharing?
Let me see. Oh, actually.
Keep it open.
Just give us 1 second here.
Yeah, perfect.
That's the Chrome tab, though.
we don't get this up in a second here, we'll ask Deepak for you to do it from yours, but I think we might just pull it out in the nick of time here.
Okay.
Window.
Maybe I'll just do entire screen and then just shift it.
Okay, sure. So are you all able to see our screen now?
Yes.
Yes.
Fantastic. All right. Well, we're
Awesome.
so excited to talk to you today about insights and impact and how partnering with Aidoc and incorporating artificial intelligence into our PERT practice has been pretty transformative for our practice. Has really kind of superpowered what we were already doing, which we were very proud of the PERT team that we put together. But this has really allowed us to extend our capabilities in fantastic ways, and we'll just tell you our story. So today we're going to talk about Cedars-Sinai imaging and AI, our PERT team, how AI came to be integrated into our workflows, and the impact that it's had. We're going to show some cases and just talk about some of the benefits that we see in our practice thanks to the capabilities of artificial intelligence. So a little bit about Cedars-Sinai. It is a big health system, over 1,000 licensed beds, 5 hospitals and over 40 locations, over 1.8 million outpatient visits a year, 125,000 ER visits, 50,000 admissions. In terms of PE, we get at the main hospital over 400 PEs annually and over 50 PERT team activations. And not only on the shoulders of the PERT team, but in many ways, it's really a wonderful place to practice. The #1 hospital in California, if you put any faith in those rankings. But really a world-class medical center, and we benefit from that all the time in terms of the people that we get to interact with. We are very technology, I think, embracing as an institution, as a department here of imaging. We've been early adopters of artificial intelligence, not just with Aidoc, but with a number of artificial intelligence companies. We were the first, as Deepak mentioned, we were the first US site for Aidoc. We went live with 4 use cases in 2018. And progressively over the years since have integrated more and more artificial intelligence applications that have integrated into our imaging workflow. PE was actually one of the first use cases that went live here at Cedars, not necessarily in the manifestation that we're going to demonstrate to you today, but in terms of enabling the radiologist reading the scans to more readily identify PEs when they were present. And this doesn't only encompass PE, it encompasses a number of different applications, neuro applications, including cerebral hemorrhage, C-spine fractures, vascular applications like vessel occlusions, other surgical emergencies like free air. So it really spans a lot of the kind of work that we do as imagers. And it empowers the imager to get through a lot of the more arduous pattern recognition aspects of our work to work through more quickly our work list. We're also actively engaged with a number of other AI companies and different vendors who add other really cool widgets and functions to our work. Looking at Aidoc and the volume of cases that are put through the different Aidoc algorithms over time, you can see it's just pretty explosive growth over time. This is looking at January 22 through December 23, and you can see over a 10-fold increase in the number of scans that are just put through the Aidoc imaging software algorithms that are sitting on our desktop and analyzing all of the cases that come through. And I'll demonstrate what I mean by that. But as we've integrated more functions, Aidoc is just doing more and more work in the background, letting us do more work effectively. So this is what it actually looks like to the radiologist. When we're reading, there's a widget that sits on our screen, that little orange box that can expand out. And with each case, that orange box will have the data on that patient. As we open it, that patient will come up, and all of the widgets that have been applied to that case will read out their interpretation. So in this case, you can see it did find that there was a positive PE, and it read an RV-LV ratio of being increased 1.36. We use 0.9 as our threshold for the algorithm. And it tells you that there aren't other findings, so pertinent negatives, including dissection, free air, rib fracture, things like that. In addition to this, so this is telling me about the case that I might have up reading. It'll also notify me when there is an emergent finding anywhere in the work list. So if I'm just reading cases and an aortic dissection happens to find its way, be scanned on one of our scanners, Aidoc has already seen that, and it'll notify all the radiologists, hey, there's an emergent finding. You should probably open this case right now because this needs urgent attention. So as you can see, it sort of sits down there out of the way. It's not really interfering with our workflow, but it lets us know when there's an emergency in a pretty non-intrusive way. And it also gives you the information on the case that you're reading, so that you'll still go through and do all of your standard pattern recognition reviews as you normally would do, your normal search pattern, but it'll highlight the positive and negative findings that it's applied to that study, that it's derived from that study through the algorithms that it's applied. So this is just a kind of case example for how that might look. This was a contrast enhanced CT of the head, and this is all happening in the background. So this is while the diagnostic radiologist is working through their day and reading studies, and this contrast enhanced CT gets done of the brain. And these are all that's the menu basically of all the possible algorithms that could be applied to that study. And Aidoc will then select based on the study type, so contrast enhanced CT of the head and neck, and the field of view, what parts of the anatomy are included in the scan. And the blue ones were not applied because they were not appropriate to that study or that field of view. The orange ones were applied. And then on the right, you can see that it had 2 positive findings. So it did find a medial vessel occlusion. So this was a study that was done for stroke, and it found a stroke in the brain. But it also happened to find an incidental PE. And in that patient, we would never have known that there was a PE in this patient, except for the fact that on a few of the upper cuts of the lungs that were included in that scan, a PE was incidentally noted. Hopefully you can still see this. No problem. And that patient then ended up going and having a formal CTA of the chest. We diagnosed a pulmonary embolism. That patient went on to treatment for pulmonary embolism that same day, whereas they might have never been diagnosed or diagnosed several days later when they became much more unstable. So huge value add from having this working in the background. Yeah, throw them back to me the same day. So Maida, if you want to tell us a little bit about the PERT.
Yep, thanks. So, as Jonathan mentioned, we had a pretty well-established PERT team prior to us utilizing AI. So AI kind of just, it made us better at what we do and just integrated into our already existing system. So at the moment, we have around 10 PERT team members across the hospital. We have our interventional radiologists, we have general cardiology, interventional cardiology, a few of us from pulmonary critical care, and actually hematologist as well. The AI PERT workflow has dramatically improved our team's awareness of patient flow and volume, because we'll talk about the kind of system we had before we had AI, but we would essentially rely on us getting consultations from the primary teams, but now we get we get information about these PEs directly. So we're pretty aware of what the volume and the flow is. And it has facilitated very close collaboration between various specialty members, because all of us have access to this app and we're all getting the notification at the same time. So even before I call Jonathan for a case, he's already aware about the case, and he knows that, I'm doing this procedure, maybe I need to triage this patient a little bit earlier. And it has definitely enabled us to have more careful and comprehensive data collection. So I thought it would be essential to kind of talk about why we really care about PE. This is from a publication in 2016 by Beccattini. And it really highlights how we think about PEs. So, when we're talking about PEs, we're really putting them into these boxes. And we have unified this verbiage so that when we talk to each other, we know how critical this patient is. So patients would be either low risk, intermediate low risk, intermediate high risk, or high risk. And as you can see in the table, the death due to PE at 30 days is 15.2% with high risk. With intermediate high risk is 4.8%, intermediate low risk is 2.1%, and low risk is 0.5%. So even though it looks like it's 2.1% and 4.8%, that's a pretty significant number. And as a community, we've been striving to get these numbers down. And as we delve into our cases that we're going to be talking about, we're going to realize that there are a lot of factors that that cause these high mortalities. Awareness about the disease, access of care, delivery of care are huge components of this. And how artificial intelligence assists us to get to our target to decrease these mortality is very important. So these are our comprehensive PE algorithms that we have at the moment. So we know that the algorithm, it runs on a dedicated CT pulmonary angiography exam. It can also detect incidental pulmonary embolisms the algorithm runs on all contrast enhanced CTs with sufficient pulmonary anatomy. Like Jonathan gave the example of the case prior, if it's a head CT, but if you are looking at the pulmonary vessels, and if there's a pulmonary embolism, we'll get a notification. It'll measure the right ventricular to left ventricular ratio between both the ventricles, which assists us in also categorizing the patient. So what's important is that, us as users, we don't want to have alarm fatigue, and we don't want to be notified about every single pulmonary embolism that's out there. We want to be able to triage our patients and get them the care they need quicker. So these pulmonary embolism and incidental pulmonary embolism algorithms, they screen positive for PE. That's quite a tongue twister there. The automated RV to LV segmentation screens positive if the ratio is more than 0.9 that we've set for our institution. And it'll screen positive if the clot is present within the main right or left PA, so it's central clot. So if all of these categories are met, that is when we would get a notification. And it also monitors key labs and vitals that are all a part of this app. And you can just toggle between these screens and be able to look at not only the imaging, but also what the patient is doing in real time. So this is what it sort of looks like. We'll get a notification on our phones. And when you open the app, you'll be able to view this image, and you'll be able to scroll back and forth to look at the whole image. It's a pretty high quality image, so you don't really lose much on the quality there. And then you can risk stratify based on the suspected findings, based on the RV-LV ratio. And this is, I'm pretty excited about this. That's upcoming for us, but the EHR data will be able to soon visualize heart rate, blood pressure, oxygenation for the patients, looking at all of their labs, and if an echo was performed, and you're able to calculate what risk category they fall into. And then the very cool feature about it also is our HIPAA compliant chat offer that we can just, whoever's on call will be able to sort of speak with each other, share the case with each other, and look at just this one app that'll give us all the information that we need about the patient.
So looking at how our workflow has evolved over time, the PERT workflow before we introduced Aidoc was as follows. and this is probably pretty similar to most of the world beforehand in terms of places that had a PERT team in place. As patient was scanned and had a PE and they got a CT pulmonary angiogram, the diagnostic radiologist would have to get to that scan on their work list. They would read the study. They would make the finding. They would alert the primary team about that finding. The primary team would then have to consult pulmonology. Pulmonology and critical care are in our PERT team, the gatekeepers, the kind of quarterbacks of our team. So they receive all the consults. They would then assess the patient, engage IR or cardiology or CT surgery as necessary. We would then go assess the patient, discuss it as a multidisciplinary team, and decide on what the appropriate intervention was for that patient. So there are two real gatekeepers in this process, right? There's the diagnostic radiologist when they get to the study and when they read the study and make the finding, and then there's also the primary team. And so, you know, their workflow, their timelines, their awareness of the PERT team, of all the interventions, of the value that we bring, all those things may or may not have led to that patient coming in contact with our PERT and getting what we think are best practice interventions. And that led to a lot of delays in consultation and treatment. Our PERT workflow after introducing AI is very different now. Okay, so that same patient gets scanned, and immediately, step 2, if you look over here, 3 things happen all at once. The AI runs a PE algorithm and alerts the diagnostic radiologist about the PE. It also identifies whether there are the trigger criteria present to alert us as the PERT team. So that would include RV-LV ratio being greater than 0.9. And it'll notify us if those criteria are in place through the app and present us with the relevant clinical data. So we can then go and immediately start looking at the case and assess whether there's potentially a benefit that we can bring to the care of this patient. We can then actually reach out to the primary team and say, hey, there's a patient on your list that has this thing going on, and we think there's potentially a benefit that we can bring through this therapy. And our multi-specialty team, we're all aware of the patient right up front. We can assess the patient. We can discuss in real time, and we can decide on the intervention. A much more efficient and accelerated process. In parallel to that, the diagnostic radiologist, who's now been notified as soon as the scan gets done, can read the study in a quick fashion, confirm the finding, and also be in discussion with those of us who are assigned to the PERT team. And so, you know, just to highlight the fact that although this is really powerful, it is not overly intrusive. If you look, this thing is doing a huge volume of work, right? This algorithm has run 44,000 scans in a 12-month period of time. And in that period of time, it's identified almost 700 PEs. But we get a notification only on about 60 of those cases. So it's not constantly pinging us, telling us, you know, oh, there's another PE, and you need to stop what you're doing and look at it. When we get the notification, we know that's the real deal. We need to actually motivate and set aside time to really jump in. And, you know, we like doing that. We believe very strongly in this model of an integrated team. So, you know, the fact that it's not sort of just firing it off left and right allows us to know that this is going to be a very high yield experience. And we have looked at the data on this. This was a poster presented at the PERT Society meeting a year ago. So shortly after the integration of the Aidoc algorithm with the PERT function. And we found a pretty substantial reduction in time. We were looking at time to thrombectomy. That's not to say that thrombectomy is sort of should be the metric by which we assess the time to response, but it's a surrogate that we used. And it found that for patients undergoing thrombectomy, it reduced the time to thrombectomy by 7 hours, 40%. We also looked at reduced length of stay in the ICU by 3 days. So very significant reductions that improve, patient experience, cost of care, and we believe could be potentially tied to significant outcomes for those patients. And that is not only our experience here at Cedars, that's also been repeated at other sites, and very similar kinds of numbers in terms of decreased length of stay, improved appropriateness of care, and increased awareness. One of the things that we really confront, and I'm sure that might be true across the board in PERT teams, is that it is very heterogeneous across the medical community, the awareness of what treatments are available, what a PERT team does, and the kind of changes that have happened and the improvements in care that have been made over the last 10 years. So this has been a really powerful tool in terms of raising awareness. So we'd love to show you some cases now to kind of highlight what this has done.
Awesome. So let's delve into some cases here. So the first two cases that we're going to talk about were at an outside hospital that's one of our satellite hospitals. So this first case was a 75-year-old female with no real past medical history who presented with shortness of breath for the past 3 weeks. She initially went to an urgent care and was referred to this outside hospital around 7 p.m. When she arrives to the emergency room, her heart rate's 123, so she's tachycardic, blood pressure's okay. She's a little tachypneic, and she's saturating 88% on room air, so hypoxic. Her troponin and BNP are elevated, and a CTA is ordered at 11 p.m. That gets resulted at 11:42, reading bilateral pulmonary embolism in the distal right main pulmonary artery extending to upper, middle, and lower low branches, and left upper and lower low branches, and has had an evidence of right heart strain. So this is the imaging. I'm going to quickly go over this. So you can see these areas of obstruction there with the pulmonary embolism. So she was started on heparin drip and was admitted to the hospital. Unfortunately, at this hospital, we do not have echocardiogram available overnight. And in the morning, her heparin is still subtherapeutic with the heparin drip. An echo is finally done that shows severely depressed right ventricular function, and she has a McConnell sign, and this is around 8 a.m. And she's still persistently tachycardic and hypoxemic. At this point, a decision is made that the patient should be transferred to the main campus for higher level of care around noon, and she's switched to Lovenox. When she arrives to Cedars-Sinai main campus, she undergoes an ECOS procedure where 2 6 French femoral sheets are placed in the right femoral vein, and TAP infusion at 1 milligram per hour for 6 hours is done. And after the 6 hours, both the sheets are removed. The patient is discharged the following day on a DOAC. And she actually follows up with me in clinic, and she's been doing great, going on cruises and just living her best life. And her right ventricular function is back to normal. So the one thing I wanted to highlight here, and we'll chat about it after we talk about the other case, is that the total time to therapeutic heparin and intervention was more than 12 hours. So that is a pretty significant time, because we're not just talking about the intervention here, the intervention being therapeutic heparin. So that was pretty delayed as well.
Yeah, and I think one thing, in terms of thinking about this case, right now we have satellite hospitals under the Cedars network, and Aidoc, unfortunately, is only deployed currently here at the Cedars main campus. And so we're actually kind of almost living in two worlds as a team, right? Yeah. We see certain patients that come to us through the satellites that we're experiencing even today, these kind of delays in care. Whereas here at the main hospital, Aidoc has sort of accelerated that whole process. So it's really highlighting for us, luckily this patient did well and no harm, no foul. But at the same time, our concern is these patients can progress over time. Yeah. They come in as a low intermediate, they can progress to high intermediate, they can progress from high intermediate to
high quickly, yeah.
Pretty quickly. And if it's not recognized, these patients can kind of deteriorate on the floor and be missed. And so that's where we really believe that I think changing the game here can really affect outcomes.
Right, right. And I think you would agree that most of these patients who we end up getting from outside hospitals, they're actually pretty complex cases that need a lot of attention. So, Aidoc will, or any artificial intelligence, honestly, will help us sort of streamline that process for us.
Yeah, flag those patients.
So case number 2, 76-year-old male, has a history of prostate cancer, congestive heart failure, coronary artery disease, so multiple comorbidities, presents to an outside hospital with shortness of breath. The EMS picked him up. He was saturating around 66%. And in the emergency room, he's found to be tachycardic. His heart rate, his blood pressure is okay. Respiratory rate is 32. He's saturating 66%. That's improved with the use of CPAP to 85% only. His D-dimer and troponins are elevated. He's not able to lay flat, so a CTA cannot be performed. A lower extremity duplex is ordered, but again, it's unavailable at night. The intensivist is called, and given the high clinical suspicion of pulmonary embolism, the patient is started on heparin.
I just want to highlight on that, that, as you mentioned, medically complex patient, right? Prostate cancer could have meds, congestive heart failure, coronary artery disease, a lot of reasons for shortness of breath in this patient,
Right.
and even tachycardia, right? So, kudos to the team for recognizing it and appropriately responding in the absence of the diagnostic workup that we would normally want to apply.
Right, absolutely. The high clinical suspicion was key here.
Yeah.
And sorry.
This was obtained the next morning, is that right?
Yeah, this was obtained the next morning. So this is at 12:45 the next morning. The patient arrived the day before. So finally, when the patient's kind of stabilized, able to lay down flat, he's sent for a CTA. And here you can see the images. So you see these areas of clot right here on the right and on the left, pretty extensive clot burden there.
All upper and lower lobe. Filling defects, pretty sucked in there, the clot.
And then here you see some reflux into the IVC, which also tells us that there is some right heart strain happening there. And then a lower extremity duplex is done in the morning again. That shows occlusive DVT from left popliteal to the femoral vein. So pretty significant. And a TTE shows severely dilated right ventricle, severely depressed right ventricular systolic function. There's mild to moderate tricuspid regurgitation, and there's elevated pulmonary artery systolic pressure. So the patients actually started on inhaled epoprostenol because that's what's available there. And the patient's transferred to the main campus to sort of keep him stabilized for the transfer. He arrives here at 3 a.m. Heart rate is sort of better than before, still kind of tachycardic. Blood pressure is still holding. Respiratory rate is 22, and because he's on inhaled epoprostenol, so that's helping as well. And pretty significant oxygen requirement of 25 liters and 100%, saturating 95%. And then everything is sort of teed up, and the patient is taken for a thrombectomy at 11 a.m. And I'm going to let Jonathan sort of talk about this. What be the images that we see here.
Sure. So these are, pulmonary arteriograms. As you see, we've gotten a pigtail catheter up into the right pulmonary artery on this image, and we're injecting contrast. And you see there's a little bit of filling of contrast into the upper lobe branch there, and that's the vein, but there's absolutely no filling, dense occlusion of the right interlobar and lower lobe pulmonary arteries. So very significant occlusion, which I think accounts for the level of obstruction and increased strain on the right heart. And then on the left side, a pretty similar picture. Minimal filling of branches there into the lower lobe. Very, very little perfusion of that lung. So very significant PE. I think as we progress with our understanding of PE and we realize that decreased perfusion, decreased sort of flow in those vessels is really the key to that level of obstruction and strain on the heart. So we did an Inari flow retriever thrombectomy. This was after several passes, and you can see. So, I'm not sure the different specialties represented here on this webinar, but this is not a perfect pulmonary arteriogram, but it is better one. And to be honest, I'm not sure that we stopped here or if we kept going, but definitely
Much
progress.
Better. Yeah, much better than no perfusion.
And then on the left, and here you can see, I think this injection was carried out a bit later, really good reperfusion of that left lung. So that to me is a very good sign that we've done important work in reperfusing and lowering the strain on the right heart.
All right, so post-procedure, he actually has improved oxygenation. His inhaled nitric oxide is weaned off. Oxygen is weaned off at day 5, and the patient's discharged on a DOAC. And since this was a recent case, he still has to be seen in our post-PE clinic. The next 2 cases are actually the cases that we encountered here at Cedars-Sinai Medical Center. So this was a 49-year-old male with a history of hypertension and hyperlipidemia who was admitted for right total knee arthroplasty. Post-operative day 1 developed sinus tachycardia to around 113 and a new 6 liters per minute oxygen requirement. His EKG was consistent with a right bundle branch block, and his troponin and BNP was elevated. The patient underwent a CTA with extensive bilateral pulmonary emboli. An Aidoc notification was obviously sent immediately to the PERT team, and a CTA official read was actually read at 8:20. But what's amazing is that the consult note for a multidisciplinary discussion was already started and documented at 8:22. So even prior to us getting an official consultation, we were already aware of the patient. And mind you, this is 8:22 p.m., so this is after hours. So we're able to respond pretty quickly. This was the CTA that was done. And here again, you can see all of these clots, bilateral.
A lot of strain on the right heart there. You can see the right ventricle is very enlarged.
An echocardiogram was done that showed a moderately dilated right ventricle, severely depressed RV function, mild tricuspid regurgitation, pulmonary artery systolic pressure elevated at 31 millimeters of mercury, and a low normal ejection fraction at 52%. A lower extremity duplex revealed pulmonary vein deep venous thrombosis. So at this point, because there was a recent surgery that was just a day old, there was a multidisciplinary discussion that was done. Decision was made to start the patient on prophylactic heparin dosing, see how the patient tolerates it, monitor for bleeding. An IVC filter was placed to prevent further embolization, and with the plans to intervene if his condition were to become more unstable. And then after there was no sort of sense of any bleeding from the patient was taken for thrombectomy the following day with clot removal from both sides.
And here you can see this was a penumbra case, I think a flash case with this was actually an injection done showing some filling defect. That catheter is then sent into those different branches to aspirate out the clot. But this is a cine, so not the same subtraction image to highlight the clot, but I'll try and slow it down and show some of the filling defect in the expected area of the vessel. It's just kind of a very heterogeneous filling right there. You can see you'd expect that to be much darker, but you see a kind of meniscus sign around the clot. And then on the other side, similar findings, but much improved after extensive aspiration of clot. Still some residual clot there for sure, but continued improvement.
So the pre-procedure PA pressure the mean was at 27 and improved to 20 after the procedure. An echocardiogram was performed the day after that already showed improvement in the right ventricular size and function. The patient was off oxygen, was ambulating the following day, was started on a DOAC, and since he could tolerate anticoagulation, his filter was removed. Case 4. So this is a 76-year-old female. She has a history of hypertension, GERD. He presented with a mechanical fall with left wrist and right patellar fractures and has an extensive history of VTE in family. On day 2 of her admission, she started developing shortness of breath, new hypoxia, and tachycardia while she was working with the physical therapist. She was tachycardic to a heart rate of 120. Blood pressure was okay. Tachypneic and hypoxemic to 94% on 3 liters of nasal cannula. Her labs showed us troponin elevation and BNP was normal. A CTA was obtained, and we'll show you the images. Aidoc was notified, and PERT team was activated. A lower extremity duplex was actually normal, and her echocardiogram showed us mild right ventricular dysfunction. So categorized, all of these cases are categorized as intermediate high risk.
Absolutely.
So here you can see some clot on both sides here.
Yeah, definite filling defects bilaterally. But and the right heart over there is definitely enlarged. But I think important to note, clot burden is not quite as significant as some of those other ones that we were looking at before.
Yeah. There's some reflux in the IVC again,
For sure.
which again, I agree with the clot burden doesn't really correlate as much with the clot burden here. So the patients actually started on Lovenox, 1 milligram per kilogram BID, therapeutic dose. A multidisciplinary discussion is undertaken and discussion with the patient as well. The patient has started to improve symptomatically, just apart from this tachycardia. And there are plans to just observe the patient on anticoagulation and to escalate care if unstable, which honestly is not very uncommon with what we do. I feel like our PERT team is pretty appropriately conservative and appropriately, aggressive when it comes to interventions. And the patient continued to improve just based on just with this anticoagulation. She's transitioned to a DOAC, and she's discharged home, and she's followed up in a clinic, in our post-PE clinic, and actually has normal TTE. So her right ventricle is essentially normal now. She's on lifelong anticoagulation because of this extensive family history of thrombophilia. And she continues to follow up with us in the clinic.
I think that's a very important point, Maida, that our value as a PERT team is not that we're trying to perform more procedures on more patients. It's actually that we're trying to get patients to what we believe is best care based on all of the appropriate specialties, looking at the patient and making that recommendation. And it's based on us being aware of everything that's out there and doing it in a timely fashion.
Absolutely, timely fashion is key here. Okay, so go on.
Oh, please.
So what's next? Well, I'm very excited about this. We're excited to have our FHIR integration that's going to be complete in 2 weeks. So hopefully, we're Gen Z, millennial, I don't know what we are, but somewhere in the middle there. But we love our phones. We want everything. Yeah, we're old. Everything in one app. Like that's ideal for me. I want to see the images there. I want to see the labs and vitals. And like Jonathan said, that people can transition from one box to another box. Like just because we're placing them in the intermediate high risk does not mean they're going to stay in the intermediate high risk. So what this allows me to do is that if at 12 p.m. I saw the heart rate at 111, and if I'm looking at the heart rate trend going up, and I had categorized the patient as intermediate high risk, I'm already like cautious that this patient might deteriorate, and that is valuable to me. So I'm really excited about that. And 2 weeks, hopefully, we'll have that active for us.
Yeah. And, as you can, I'm sure tell, we've been really pleased with our experience integrating this process into our workflow. The most important thing that we feel that this does is it connects us, the people who have a lot of specialized knowledge, to the patient. And that's not really something that has to happen only at Cedars. It doesn't have to happen only in academic centers. It really can happen in community centers because there are PERT teams. There are people who have specialized expertise everywhere. It's just that not everybody in the medical community has that when it comes to something as complex as taking care of patients with PE. The app simplifies the whole process and tells the people who do have that knowledge who is high risk, so who we should really focus our attention on. So it really puts them on our radar, right? Not every clinician out there knows the European Society guidelines for risk stratification that we mentioned to you. They're not all aware of all the treatment options. This field is moving very quickly. 5 years ago, most of these patients, if they got a procedure, it was just going to be thrombolysis. Prior to that, it might have been spinning a pigtail. So many different things that used to be done that are no longer done. We didn't mention, surgical embolectomy, which is still very much part of the treatment. And beyond all that, as this field is rapidly moving, there are now a lot of clinical trials in this space, right? And so actually 2 of the patients that we mentioned here were actually included in our ongoing trials here at Cedars. So the app has another sort of dimension of value that it brings to our team, which is that it allows us to more readily identify research subjects for our trials. And that is really important in terms of advancing the knowledge in the PE space.
Yeah, we owe that. We owe that to our next patients who come with PEs to have this robust data for us to dictate what we do with them.
So that's all we have for you today. This has been wonderful to tell you a little bit about ourselves and what we've done here with Aidoc. We'd love to hear your guys' questions.
Okay. Thank you so much, Dr. Steinberger and Dr. Yakub. This was great. We do have a couple of questions here, so I'll help moderate that. The first one is, can you speak to your experience with false positive rates with the PE algorithms with the CT scans and Aidoc?
Sure.
I mean, I guess like what does false positive mean, right? Like, I think the algorithm is picking up central clots, is picking up RV-LV ratio, and essentially, if it picks up those things, they're essentially positive. I think the false negative would be that, if you're thinking they're intermediate high, like they might not be in the intermediate category, where we might not have them undergo any like extensive procedures, and we'll just stick to anticoagulation. In that sense, they're positive. There's still pulmonary embolisms that end up being positive.
Yeah, I mean, so we got a notification actually overnight on the app, and that was a patient that does have a PE and does have an enlarged right ventricle, but it's actually a pretty small burden of clot, has pneumonia and really consolidated lung on one side. There is definitely a filling defect in the pulmonary artery there. Does that require, a formal PERT activation? I think we looked at those images and felt, no, that's not going to be, that patient's right heart enlargement is not secondary to this PE. And looking into the chart and quickly kind of doing a quick chart survey, you realize, all right, that's probably not somebody that we're going to necessarily need to weigh in on. And the diagnosis has been made that patient does have a PE. So they will be put on anticoagulation, but they don't need sort of advanced therapies. The false positives in terms of just, low quality scans that do happen with a lot of breathing artifact and consolidated lung and other things, surprisingly unusual, I have to say, with the app. It really does identify the pulmonary arteries, and it really does identify filling defects in the pulmonary arteries. Streak artifact and other things like that can certainly happen.
And I'd like to add 2 more things. So the app actually has a feature where you could send feedback to the app if this was a false positive or false negative. And I've never used it. But I mean, that is a feature that's available there. And like you said, occasionally we'll have some chronic clot with RV-LV ratio being off, and we know that patient still needs the care. And then apart from getting PERT alerts, they're like PE notifications that we have that we were not pinged on our phone for, but we have like an entire list of all the patients who have had the diagnosis of a clot. So we also have that information there.
Yeah, we deal with also some very, very complex patients who have, chronic pulmonary hypertension, have like a lot extensive cardiothoracic surgery and abnormal vascular anatomy.
Right.
So, sometimes that'll maybe throw the algorithm a little bit for a curveball, but I honestly think that it's shockingly low.
Yeah, I'd agree with that.
Gotcha. Yeah, and I can answer from the company perspective. We do have a whole AI operations team that manages and monitors the performance of our algorithms. And so we do keep on top of that to ensure that there is no data drift and that the algorithms stay true performance-wise over time. So, and Dr. Yakub, you mentioned the feedback function as well. So we do take that seriously and ensure that we, when we retrain our algorithms, we are taking that into account. Okay, so another question that we have here is specific to case 3. So I think more directed to Dr. Steinberger. Can we do penumbra with an IVC filter on that case?
So I think the question is with regards to, can you do a femoral access and put a penumbra catheter up into the pulmonary arteries when an IVC filter is in place? So you'll want to be careful when you're passing anything up through a filter, but absolutely, we do. So the penumbra flash catheter is 16 French, and so I think if you look carefully at that case, there was a 16 French sheath that was up into the main pulmonary artery, and then the flash 16 catheter was advanced into the right and left pulmonary arteries to do the thrombectomy. We've actually done it with 20 and 24 French sheaths. Again, you want to be really careful passing through the filter. You want to do that under fluoroscopic guidance and make sure that you're passing through the legs of the filter and not catching the filter and causing potentially a significant issue by moving the filter or dragging it along the vessel wall. So it's something to be careful with, but it is something that absolutely we do.
Okay. Thank you for
and
that.
Also on removal, you'll want to watch, anytime you're passing through that filter, but your sheath should kind of stabilize your access through that filter, and then the catheter can go in safely.
Okay. Let's see, another question we have here. I think we have time for this one more. Are you speaking with your administration about ROI and clinical impact of this solution and for your PERT team broadly? How are you managing those conversations with your administration?
I think we're in a privileged position here at Cedars because our administration has been the early adopters of the Aidoc, software. We are the first site, right? And we've been involved not only on the as a user, but honestly on the development side as well. We've collaborated with Aidoc on early testing of these products and things like that. So not as difficult an argument here in terms of trying to convince our leadership of the value. They saw that value even before these algorithms were deployed. But certainly, I think the metrics have been tracked by Aidoc that make a very strong case for the value that it brings to patient care. I mean, if you look just at length of stay and the data that's been repeated across institutions, there's a very strong case made there for the ROI. You decrease an ICU length of stay by 1 day. That is more than enough to justify bringing in a technology like this.
Yep, that's great. And I think last question, can you explain your hub and spoke workflow when you receive outside patients? Does the spoke site have Aidoc installed? And I think you guys alluded to this, but please go ahead.
So we don't have, the spoke site does not have Aidoc installed, and there are talks to start integrating Aidoc there as well. So there's a lot of interest from our side because our group now goes to this satellite facility, and we're the intensivist there. So just by virtue of us being there, we're sort of, keep an eye out for these cases. And since we already have a transfer process that's very sort of linear, very easy to go through from these outside hospitals to the main campus, we'll push through those transfers wherever we think the patient needs higher level of care. So, hoping in the next few months, hopefully we'll have Aidoc installed at our other sites as well.
Yeah, there's a little bit of heterogeneity in terms of like departmental coverage of these different sites. So those are actually different imaging departments at those satellite sites, and so they haven't necessarily integrated Aidoc. They don't work even off the same packs that we do. So that's a process that's still ongoing, right? The integration is not. It's a process and it takes time. So we will get there, I think, before long, but we haven't quite gotten there yet.
Yep. Okay. All right. So one more question did come in, so I will cut it off here. I promise. So is there any risk or medical legal exposure when the PERT teams receive a PE alert before the radiologist reviews the case and provides an official consult?
I don't think so, because we are the PERT team, so we are responsible for taking care of patients with pulmonary embolisms. And I think the one thing that goes in our favor is that our PERT team was so well established even before all of this that we have very good relationships with the primary teams, and the primary teams know what our function is. So they definitely, once in a while, will have to solicit a consult from them, and they don't really mind that. And then just going into the medical legal a little bit, just the one step before our FHIR integration is sort of using our two-factor authentication, which sort of keeps our app very sort of tight with regards to sharing any patient information with anybody. So it kind of keeps us kind of safe from that end as well.
Yeah, and I think in terms of, I think the question might also lead to some discrepancy with what the diagnostic radiologist might read in the scan versus what interpretation we may take from it. But the diagnosis is a clinical one, right? It is there has to be the finding of a PE, and I think there's enough expertise in the PERT team to be able to look at the scan and know, is there a PE there, right? Then the question becomes a clinical question: are they experiencing signs and symptoms of sufficient right heart strain to generate a PERT response? And so that is not really uniquely resting with the diagnostic radiologist. There's also I think a political question that applies, which is, we are a PERT team that is not we're kind of inserting ourselves before the official consult has gone out, and I think that's another question here, which relates less, I think, to medical legal exposure and more towards just how to navigate it politically. And I think that's going to be institution specific, team specific. Like Maida said, I think we have really good relationships around this hospital, and we also don't push ourselves onto, primary teams that don't want us involved. And if they have the sort of expertise to manage those patients and they don't, or they're just not interested, we respectfully back off. It's more just saying, listen, I don't want this patient to sit there for another 8 hours before you're aware of this and pick up the phone to call me. I'm just letting you know I know about it, and I can be if I can be of help, I want to.
Yeah.
So I think you have to manage it as appropriate to your institution. But I think if you see it as sort of a patient-centric thing, we're all part of the same institution taking care of these patients. So I think medical legally, it's not inappropriate. But I think the question, is sort of complex in terms of, it's not just an imaging finding, it's not just a clinical finding, it's really an amalgam of the two.
Yep, understood. That's a great answer. Well, we are right at the top of the hour, so we took up the full 60 minutes, and I want to thank everyone for attending, and I want to thank Dr. Yacoub and Dr. Steinberger for this wonderful presentation. And I'll let you all get back to your day. So thanks again, and appreciate your time. Take care.
Thank you so much.
Thank you.
Bye.
Bye-bye.